Okay, so what did we talk about last time? We talked about the thyroid gland, which controls what? T3, T4, which affects metabolism. Too high, metabolism's up. Too low, metabolism's down. Parathyroid affects what? Calcium. Every sign and symptom has to do with either calcium being too high or too low. What else did we talk about? Did we talk about anything? I don't think so. I think that was it, wasn't it? Yeah, that was it. Alright, so today we have to start out by talking about what is antidiuretic hormone. Antidiuretic. If you give somebody Lasix, what does it do? It makes them go pee. You give it to them at night and they're mad at you because they have to get up and go pee all night. And then you put all the throw rugs on the floor and they get up and fall. The antidiuretic hormone. That's terrible. Which one is it? Which one is it? Cherry cola? Oh yeah. I'm committed now. I gotta drink it. Oh, it's terrible. Give me that. That will not be. I gotta drink it now. Antidiuretic hormone, where does it work? In the kidneys. So it goes down in there and it tells the kidneys, okay, no more. We're not letting any more pee out. So, holds on to water, no more pee comes out. Antidiuretic. So, if there is none, then your body just does what? Pees and pees and pees and pees. So if all the water leaves, what's left? Salt. Stuff. If all the water stays, how much stuff have you got? No, if you got all this water and you have hypervolemia, how much stuff you got? This much. If all your volume's gone, how much stuff you got? This much, right? Dehydrated, overhydrated. Does that make sense? This is like we was talking about this the other day. How many people from the South? Like really from the South. How many people from the North? Y'all might not get this. This Mama's sweet tea. Y'all know what I'm talking about. Mama's sweet tea. This glass. And this the original level of tea. Right? This your volume. This the volume. Look, she already back there doing it. How much sugar she put in it? This much? How much stuff? A lot. Girl, you ain't got no water left in there. So you basically dehydrated. You got all that stuff and no volume. If you got unsweet tea, blasphemy. Here's your cup. There's your tea. There's no sugar in it. So, okay, here's the stuff. There you go. You're not dehydrated, you're overhydrated, right? What is that going to look like in your labs? And I know we haven't got to it yet, but guys, I want you to think. We're not just going to read off these PowerPoints. What about your hemoglobin? Not even hemoglobin, your hematocrit. If you're dehydrated, it's going to be high. High. You're dehydrated. Your volume is gone. You're left with what? It will. You're left with stuff, and that's what your hematocrit is looking at. What about your BUN and creatinine? It's going to go up. So, did I hit the wrong button? cannot teach this without talking about these labs. These labs are going to be on your test. Guys, don't get caught up in the weeds. And I know y'all think some of the ways I say stuff is funny, but it is all about the stuff. When you talk about hypertonic saline, how much stuff is in there? A lot. What is normal concentration? What is normal saline? 0.9%. Hypertonic saline is what? 3. A shit ton of stuff, very little stuff. Why do we give, and we're going to talk about this, why do we give hypertonic saline? To pull that fluid, right? Osmolality looks at how much stuff is in body fluid. I don't care what fluid. Blood, urine. So, let's go back to this. If you are dehydrated, how much stuff is in your blood? Your osmolality is going to be high. How hard was that? Guys, when you get these questions, stop. If you need to draw it out, Mamaw sweet tea, draw it out. Because it's very easy to get confused. I found a chart last night, and I know y'all think, yeah, she has shit all the time, just after we get into class. I know, I can't help it. I find these things, and I need to add it. And it lays all of this out. I will put it online so that you guys can see it. Urine-specific gravity is the same thing for urine. It is a test that's specifically for urine. It looks at the amount of stuff in the urine. If somebody is peeing and peeing and peeing and you have this huge amount of urine that is diluted, what is this amount of stuff going to be in polyuria? Low. There's no stuff. Right? Now what if you got this much? This much urine. It's going to be highly concentrated. What's it going to look like? Deep yellow. I know, you got to do that face with it. It's going to stink. It's going to be orange and yellow, and it might pour out in a gel. I'm serious. This is what we just said. A lot of volume, not a lot of stuff. That's the unsweet tea. If they're dehydrated, that's all that's left. Their volume is gone. And the stuff that we're talking about specifically with SIADH and diabetes insipidus is what? And somebody already said it. Sodium. Sodium is what gets us into trouble with these two. What does sodium, we talked about the effect that calcium has in the body. What does sodium affect? The brain. Why does it have that effect in the brain? It starts to make it swell. Cerebral edema. And we're going to talk about that specifically. What does the word anuria mean? No urine. Don't let this name fool you. I don't know why. And I heard a lady describe why they call this diabetes. It has nothing to do with your pancreas, sugar, beta cells, nothing. DKA, nothing. Don't even think about that. Type 1, type 2, no, nothing. Diabetes insipidus. This is anti-diuretic hormone only, ADH. This is the patho. What did we say? diuretic hormone against diuresis. I don't have enough. What's going to happen? You're going to pee a lot. You're going to make the Foley explode. It won't stop. So if I don't have enough, how do I stop it? You give it. You know what the other name for ADH is? Who said it? What is it? Vasopressin. Have y'all heard of that before? Have y'all seen it? Where? In the ICU. It's given as a what? Vasopressor. How does it work? It holds on to fluid and increases your volume. Look at there. You can remember DI, they are dry inside. So, if you are peeing out 2 liters within 2 hours, and I think it's actually more than that, what is their sodium going to be? High. Guys, they have no volume. What's their skin target? You're going to pick it up, and it's going to tense, and it's going to stay. If any of you, guys, this is a very valuable tool. It really is, and I think it's very underutilized. Now, you have to be careful in the elderly population, because I promise you, now, I do not count myself as elderly, but I'm older than I think anybody in here. My skin tints more than y'all's, because you're younger than me. And as you get on up in age, it still just tints because the subcute goes away. If it truly tints, and you're like, so if you ever get a chance to see that, you need to look at it. Where else can you see dehydration? Get them to open their mouth. And this will break your heart if this is abuse in the elderly. Get them to run their tongue out. It will be furrowed. It will look like the desert. Lips will be dry and cracked. If they are dehydrated enough and it's a child, they will cry and not make tears. That's dangerous, dehydrated. This is not this is real world. I know we're not peds, but we talk about it anyway. What's another sign of dehydration in a child? Baby. And guys, when you feel that fontanelle, then don't go poking on it. But when you're doing that, that's a horrible sign of dehydration. What causes it? Hey y'all, watch this. Hold my beer is the number one thing that I have seen. I told you the guy tried to jump off the roof of the 3rd floor and get in the swimming pool. He should have jumped further. Unfortunately, our military, what are the ones that work with explosives? DOD. Thank you. I had to take one that we flew across the country to
Walter Reed?
Yes. And he had diabetes insipidus, and he didn't get out of the way in time. His wasn't as bad. What he was on into his treatment. The other guy, it had happened like a week ago. Surgery, if you're messing with the pituitary, or if there's a pituitary tumor, central nervous system infection, or if there is why is it saying if there's a nephrogenic? If your kidneys have an issue, and that's where the anti-diuretic hormone works, and your kidneys ain't working, it ain't gonna be working. Does that make sense? So, If you're dehydrated, what's your blood pressure? Hypotensive. Polyuria, 2 liters. What kind of shock? Guys, truly, hypovolemic shock. What's your top 3 priorities? Volume, volume, and more volume. What kind of IVs? Large bores, as big as you can get them. If I could get bilateral 14 gauges, okay. You think it's going to be easy getting an IV in them? No. They're going to be so dehydrated. You may have to put an intraosseous, you may have to beg, steal, and borrow one of the docs. You may have to get an ultrasound guided. They need an IV, they need fluid. Is it going to immediately work if you don't get vasopressin? You've got to get that vasopressin or it's just going to come right back out. Polyuria, hypernatremia, dry skin, mucous membranes. What's polydipsia? They're thirsty. What's making them thirsty? Their brain is telling them what? You dying, and you peeing too much, you need to drink more water. Why is their urine osmolality decreased? They peeing all their volume out. They have polyuria. How much stuff? None. Does that make sense to you guys? Don't get caught up in the weeds. It's not hard if you think about how much stuff is in a polyuria. And urea, it would be increased. All right. Decreased urine, what about your blood? It'd be high. You've got hypernatremia. A lot of stuff. This is backwards to what we normally expect because water follows salt. This is not the case. Your salt just stays in there and your urine goes out. All of this is backwards, but it's because we don't have that antidiuretic hormone and the kidneys is not working that great anyway. We are going to do a CBC. What's really important? CMP. We're talking about diagnostics. Guys, they do have something that's called a urine sodium. For this one, do you think it'd be high or low? It might not even be existent. All their salt is where? Inside, right? Do you see what I'm telling you? Polyuria, their sodium's not there. Their sodium's in here. Hypernatremia, polyuria, nothing's in there. Nothing's coming out. The salt is staying in here. It's backwards to everything we have ever learned in pathophysiology. That's CMP. So if the sodium starts going crazy, do you think some of the other electrolytes sooner or later are going to start going crazy? Yes. I can't. Does anybody think of any other diagnostics that we might? I mean, of course, if it was some sort of trauma, they would get all the scans and all the things. I guess if they were thinking it was a central nervous infection, what would they do? But, they will do a culture, but how do they get those? They'll do a spinal tap. Get it, girl! Get it, get it, get it! Everything we ever talk about, whether it's shock, whether it's whatever, you don't give antibiotics to hypovolemia, you don't give whatever to whatever, you have to treat the cause. In everything in this career, you have to give them vasopressin. You give them all the fluids you want, it's not going to help. You're going to give them 3% saline? Hell no. This is synthetic antidiuretic hormone. and IV fluids. And we did give them isotonic. Now, after we kind of evened them out, then they would start giving them different types of fluids, like half normal saline. Y'all don't worry about that. All this is isotonic fluid. The most important thing is I have to replace that vasopressin. Then we'll worry about what's truly causing all of this. But right now I have to fix that and stop them from eating this and making the Foley bag blow up. They need to be on the telemetry monitor. If your sodium gets too high or too low, what can it cause? Seizures. What are you going to do? Guys, you've got to do seizure precautions. Because how many people that have seizures hit their head, break teeth, swallow all that blood, swallow those teeth. Now you got to do a bronchoscope and go down there and get all that stuff because you can't breathe through teeth and bones. Heaven forbid they yeet themselves out of the bed onto the floor. Blood pressure. Look at their urine quantity and quality. So if you were doing good and your volume was going down and now all of a sudden we're back up to 1 liter an hour, you need to do what? Something has changed. You need to find out why. Safe environment. Remember we talked about that, no yelling, don't go in there playing Rage Against the Machine, let the bodies hit the floor, and if the family's doing that, then ask them to leave, and if they're trying to fist fight, then go get security. Once they are beyond the trying not to get yeeted to Jesus, what are we going to tell them, especially when they get ready to go home? Guys, this might not go away if they have a tumor that's not going to be operated on. I don't want you to think that all of these are, oh my God, life-threatening, you're going to die right now. Right now. They might have this forever. So what do you need to tell them when they go home? They need to wear... Girl, and some of this like medical alert bracelet is so bougie now, like 14 karat gold. It looks all like, I'm like, I didn't know that was even a thing. Or tattoos. I'm like, but what if you got something else? Do you just get addition? See the left wrist. That would be something if I was on the ambulance responding and I get there and you're unresponsive that I would need to know. They need to know the signs and symptoms if this is getting worse. They also need to know they need to do what daily? Weigh, monitor their fluid intake. Are you going to tell them that you don't need to drink a lot of fluid? No. Here's 3 Stanleys that, what is that, 44 ounce big gulp, Bubba something? Yes, you can have it. Now, we're going to talk about the opposite in a minute. That you got too much. They gonna get that? No. Does everybody like you to tell them how much to drink? No. I had a patient who was on strict eyes and nose because he was, this is the thing, silently aspirating. He was drinking his wife's water when we weren't in there. And she called him. I closed the door because Mama took care of it. And I wasn't going back in there till she was done talking to him. And I walked back in, I was like, you all right? I said, Mr. Jones, you can't do that. Guys, I mean, how would you feel if that was you for the rest of your life? You can have these thickened liquids. You can have this for the rest of your life. These people, they can pretty much get away with drinking a lot. Now, they need to drink halfway healthy fluids. Weigh daily. You need to weigh yourself daily, same time of day, same kind of clothes on. Is the Biggest Loser even a thing anymore? Do y'all even know what I'm talking about? Yeah, they used to come in there and see, I'm showing my age. And they would come in there at the same time, and I'm like, ooh. They wouldn't have they would lose so much weight though. They would have the same clothes on, like the women would have a sports bra and some kind of pants, and the guys would just have on the pants. But same time of day, same clothes. Why would we do that? I mean, because your clothes do add 2 or 3 pounds, and for these people, if you go in and they have gained 3 pounds or lost 3 pounds, that is significant. If they're on a nephrogenic diabetes insipidus diet, do they need salt? No. Stay hydrated. Keep water with you at all times. Wear a medic alert bracelet. So, have you guys seen the salt replacements? Do you know what it is? Potassium. It is. It is. Be careful, especially with your heart. Not so much these. With your heart patient, and the ones that taste the best are 110%. Say it louder. Potassium. For your heart patients, tell them to be careful and read the ingredients at the back, on the back of your line from the back pew. Syndrome of inappropriate anti-diuretic hormone. That's the only time I'm going to say that. SIADH. So we didn't have enough. Now we got too much. Anti-diuretic hormone. The kidneys are going to what? Hold on to it. Hypovolemia, hyper. So if I listen to breath sounds earlier, would I really hear anything? You ain't going to hear a powder house. What am I going to hear now? Crack. That's you ringing out the lung. I see you laughing. Too much. Too much volume. A lot of volume. How much urine? This much. This you might want to look at. A lot of these, for some reason, small cell lung cancer is the devil. That's the devil. My mama said that's the devil. For a lot of different things this semester, small cell lung cancer, it creates is a risk factor for everything. It's like smoking. You can just go, smoking and obesity causes everything. So don't smoke and don't get fat. There you go. Oh wait, what did my son say the other day? There was a new word that he said that nacho. I'm like, what are you saying? Y'all calling each other things that I don't understand. I don't even know if this is an insult. Here again, brain trauma. The same things that work for DI, sepsis. So, DI was dry inside. No, I'm freezing now. And SIADH is soaked inside. This one, you have to worry about seizures. Why does this one, we already talked about this, why is this one such a neuro event? It's causing cerebral edema. Fluid overload. Every sign and symptom you're going to see, besides Ms. Orton putting on this backwards, is signs and symptoms of fluid overload. Pulmonary edema. You might as well say congestive heart failure, pulmonary edema, cerebral edema, peripheral edema. Is there any more edema we can throw in there? Right toe edema? I don't know. Periorbital, they're going to be swollen. Not hypotensive, hypertensive. Are your blood pressure medicines going to work? No, that's not the problem. Breath sounds, awful, crackles, hyponatremia, seizures, headache. Why does their head hurt? Swelling and their blood pressure is oh my God over oh my God. Nausea, vomiting, altered level of consciousness. The ultimate goal, you have got to stop the water retention, and you have got to manage hyponatremia. That just stayed down there, didn't it? Here again, CMP, UA, blood osmolality, and urine specific gravity. Full set of vital signs. I am going to have to pay attention to their respiratory rate, SpO2, blood pressure. God, you might as well say everything. You're also going to have to pay really attention to their level of consciousness. How am I going to keep up with that? Neuro checks. And it's probably not going to be every 2 hours or whatever. This might be every 10 minutes if it's really bad. How am I going to do a neuro check? What's the easiest way?
What's your name right now?
Hey, what's your name? And my fundamental student, I love them to death. I really love teaching them in the labs. Hey, Mr. Jones, can you tell me what your name is? Y'all don't laugh. Y'all probably did it too. And so I play like the Alzheimer's patient. I said, Mr. Jones. And then when they're completely done with their assessment, I get up and walk out. I said, I'm Mr. Alex. I don't know what you talking about. And so I'm just trying to tell them. I was like, don't do that. Or do you have sharp pain? Yeah. Do you have dull pain? Yeah. Don't give them a suggestion. Can you tell me what your name is? Can you tell me what today is? Don't rapid fire on these little. Can you tell me what today is? Can you tell me what your name is? Can you tell me what today is? Can you tell me who the president is? Can you tell me? Can you slow down? I didn't get past the second question. Closely monitor I's and O's. Daily weight. Fluid restrictions. If daddy ain't listening, you get mama involved. I ain't above telling. I ain't. Show will. Give sodium if needed. We ain't talking about salt tablets. Guys, this is extreme. What color is the label on 99.9% of these IV bags? Orange or red. Most of them are red. Why? It needs to tell you this is a high alert medication. Do you think it's ever been given when it shouldn't have? Yes. You can kill somebody with this. You can save somebody with this. What if it's just mild? I know we're talking about earth-shattering, right on the edge of meeting Jesus. You could do that with fluid restrictions, right? Maybe even dietary increasing sodium. If it's this bad, that's not going to work. Now, this is just treating the fallout. It's probably not going to do a whole lot. What do you think the biggest effect this does besides give them sodium? It treats cerebral edema. We're going to talk about talk about traumatic brain injury soon, but this is important. So these patients, their cerebrum is swelling. So if you have all this volume, right, floating around, you ain't got no stuff. This is why we don't give folks hypotonic saline, hypotonic. So you got all this volume, and then you get up to your brain, and it goes into your cells, right? What happens to your cells, right? So you have cerebral edema. This is your skull. It does not do what? It don't move. It is an enclosed thing. Unless you drill a hole in it, bust a hole in it, crack it wide open, it is not going to expand. What's going to happen? Okay? And what's going to happen then? It ain't, where's it going to go? You have a hole at the base of your brain. Your brain stem is there. It's called the foramen magnum. What's going to happen? It's called herniation. Your brain gets shoved down through a itty bitty hole. Do you think that's a good thing? No. This is game over. No longer playing records. Currently circulating the drain. Once that starts, your patient starts posturing. That's death. Yes.
So how would we know if it's related to the ADH or if it's just normal fluid overload? Like, is it the severity, and that's how we know that it's related to the ADH?
The thing is, if we're treating this, that's that. But I mean, if you just walked in and the patient, like, posturing is herniation. But if you just walked in and the patient's, you wouldn't know. I mean,
I guess I'm talking more generally, like the difference between this and just fluid overload. Like, how do we know that it's because of the ADH that they are having all this?
Like, and not just regular hypervolemia.
the thing is, if you had hypervolemia because of anything, it's still going to cause cerebral edema. Do you see what I'm saying? You don't have any sodium, so it's still going to go into your cells because of whatever reason. You don't have any stuff anywhere. It's still going to cause your cerebral edema. You have to pull that fluid out.
So the treatment will be the same?
Yes. What's the other drug? I didn't put it up here, but you can give it. It's not given a lot. Does anybody know the other drug? It's a salt. Mannitol. It's not great. It does not play well with other drugs, especially sodium bicarb. When you put it in said IV line, it crystallizes. And it gets said flight nurse jumping across the bed and grabbing the IV line. And I didn't know, this nurse pushed it and I didn't know that it actually did that. Like, guys, I'm talking about like y'all know the little rock candy?
Yeah.
That's what, I don't know what, well, I know what would have happened if it would have. And I'm like yelling and screaming at her to stop, and I just grabbed it and cut it off, and I'm like, take it off!
Does it do it instantly?
It did, and it turned a milky white color like I've never seen it. I've never given that. We always gave 3%. The patient was herniated, and so we didn't have our 3%. I sent my partner to get it. That was our protocols. She pushed the mannitol while we were doing that, and they had pushed sodium bicarb, and that happened, and I was like, oh, that's cool. Oh my God! So yeah, it does not, and so of course after that, and I stopped plus for panic when we got back, I looked it up. It does not play well with a lot of other medications. They're going, look at your drug guide. But you can't, it's still there. You can give mannitol. Some places don't have this. Mannitol is a old drug. If you are going to give it, it needs to have its own line, pretty saline, nothing else. Don't be messing with it and giving other drugs. Or if you do, flush before, well flush afterwards. Now, if it's not that bad and they go home, what kind of education are we going to give them? And they ain't going to like you at all. they might have strict fluid restrictions. They are not going to be happy. How compliant do you think some of these patients are? They're gonna look at you and say, I'm gonna drink, I want to. And they're gonna be back at the hospital. What can you tell them that can help? And some of this stuff really does help. Ice chips. Oh, that's that group that's gonna be doing the mock codes, but they might read them. Hard candies, sugarless gums. They need to know the signs and symptoms that their their sodium is dropping. A lot of times, we used to have this guy at Tenova. I can't remember why. It was not this, but his sodium would drop, and the first signs and symptoms would be nausea and vomiting, and bad abdominal pain. And his sodium would be so low, and I'd be like, "Bro, you all right?" Like I would expect him to be seizing at this point, but he wasn't. But he would tell me, because I'd ask him, I was like, "What's the first thing?" And he said it always starts with nausea and vomiting and abdominal pain. Seizures. Who else do you need to educate? You need to let their family know. If they start acting funny, and it can be anything, if that's an altered level of consciousness, they start throwing up abdominal pain, then you need to call their doctor. Alright, the adrenal glands are very, 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 very important. The hormones they secrete, glucocorticoids, mineralocorticoids, and the androgens. Sugar, salt, and sex. I told y'all we ain't talking about sexy time, this ain't that class. And I told every one of y'all, about a week or two after class, everybody in there gonna get sick. That's included. Well, no, I got to teach this summer, so I'll get sick a year and a half from now. Why is that? What is this? Your stress response. For the last 4 years, y'all have been in fight or flight. You really have. And I mean, you have at some level, and in some levels it's worse, some levels it can, but you have not been out from under this. And when it stops, your body absolutely crashes. Y'all please take care, and I'm telling, I know y'all gonna say, these aren't peaches to me all the time. No, I care about you guys. When y'all get done with this, if you want to, sleep all in bed, and I know y'all got kids, you just tell them, just go get the Tinker Toys, go run out in the middle of the road, buy those little. Y'all please take care of yourself after this. Try to take some rest, because it is going to happen. I've had all these students, Miss Horton, I got so sick. I told you it's gonna happen. Cortisol is your stress response. It reduces inflammation. It supports blood pressure. Aldosterone balances sodium and potassium and controls your blood pressure. Like I said, we ain't talking about the androgens. How often do you think all these things that we're talking about, thank God, happen in practice? I told you, I've seen DI twice. I've seen SI-ADH once. And I've seen Addison's once since 1998. And I've never seen Pheocyto, I might have mispronounced that, I don't know. They just don't happen. But the fallout usually is awful. Now the thyroid and parathyroid, you will see that. Addison's, no cortisol, no aldosterone. These are your steroids. So, if I don't have any, what do you think the treatment would be? If I add steroids. That's not mine, that's Nurse Mike or whatever his name is. Guys, I don't sell any of the blogs or whatever. I listen to them all the time. What is his? Is it Simple Nursing?
Yeah.
I know y'all have seen some of the graphics. It really is good. And he is up and up on the NCLEX stuff. Y'all don't buy I do buy his thing. It is very expensive. You can find 99% of his content on YouTube. What's the other one? Simple Nursing RN, Registered Nurse RN, Straight A Nursing. Has anybody else got a good one? Level Up RN, Nurse in the Making. There are a lot of podcasts too that are really good. No cortisol, absent, they gone for some reason. Autoimmune, here we go again, cancer. TB, HIV, or trauma. Where did we say these are? What glands? The adrenal glands. So, remember how we said with the hypothyroid, it was low and slow? Everything is low. Hyponatremia. Well, not hyperkalemia. Hypotension. Hypothermia. Hypoglycemia. This is key. You might want to remember this. What does this mean? Hyperpigmentation. Their skin is, and there is a hallmark sign to this. There's a word that they call this. It starts with a B. Bronzy tint. That's next. That's the week after next. That's lupus. That's the butterfly rash. Nice try. Yes. Hyperpigmentation of the skin it's a bronzy color if you look it up online. Their blood sugar is low, their temperature is low, their salt is low, hypotension, their potassium is high. Can all of these things get you in trouble? Yes. So if their blood pressure is low and their temperature is low, what am I going to monitor? Their blood pressure. What are your top 3 priorities? Circulation, definitely. I need to get IVs. I need to warm them up. If I get IVs, yes, blood sugar. If their blood sugar is 5, just bring it. So, everybody look at me. I want to ask everybody in here, this is a pharmacology question, one the adjunct was talking about to me yesterday. And I want everybody to tell me if you think this is a legitimate dosing thing. They had a new dosing for insulin. It was weight-based, and when the nursing, it wasn't a student, she was on another floor, and when they got the patient up to the ICU, the pump said, because you know, usually in an IV bag of insulin, it's 1 unit per 1 milliliter. It was going at 100 milliliters per hour. Does anybody see a problem with that? She was unresponsive. I don't even know what her every nursing student in here like, y'all knew immediately that ain't right. I'm like, I know. I'm like, was she alive when she got up there? What was her sugar? She's like, we don't know, but the ICU nurse was like diving across the bed to turn it off. She didn't even know the new protocol, but she knew enough to cut it off, like take it out. So, I don't know. it off and be like, what are you doing? Well,
We would have put pixie sticks in the patient's mouth.
something.
Hook it back up.
Go give me go give me a pack of sugar. 5, 15, 11,000. She's like, I don't know the patient's sleeping. I bet she is. She's finna take a long nap. With Jesus. But I'm like, I've never heard of a weight-based insulin. Has anybody else seen that? And I'm like, but the thing is that this had gone through pharmacy. Like, this went through multiple layers. It wasn't like, this was a failure on like 3 different layers. Thank God. ICU nurse was standing there when it was like, whoa, wait a minute. So, don't ever think, like, guys, if y'all were in clinicals and that walked by you, and I was up there with you and I'm not there, and you walked over and turned it off and somebody said something, you better come get me. Because I'm going to go get the DON if they're giving you problems and come down there and say, my student just saved your patient's life. You need to go tell that nurse to come apologize to my student. There is never a reason that you can't intervene. Well, what if you were wrong? Okay. I would get you to apologize to them and tell that nurse to quit being a butthole. If they don't have any steroids, you have got to replace it. You can give them all the IV fluid. Yes, we're going to give them fluids, a lot. You've got to give them the prednisone. This is like the epinephrine questions. Hint, hint. Give them the steroids. You got the order. This is a perfect world. You guys know this by now in my questions. Give them the steroids. IV fluids, yes. Prednisone, Decadron, whatever you want to give them. Now, have you guys ever heard this before? If they have this problem with Addison's, and we know it, and they're going in to have surgery, what are they going to do? They're going to give them a dose before they go in. What happens when you in 4 years of nursing school? Your cortisol levels drop, right? So, if I had Addison's and I'm going in to go to surgery, it's going to be an insult to the system. I need to give you an increased dosage. If I already know I have Addison's and I go into the hospital and I get really, really sick, the nursing staff, the hospital staff need to give them what? Steroids. They're going to go into Addisonian crisis, which is an absolute emergency. Their blood pressure goes to 20 over dead. IV fluids is not going to work. What have you got to give them now? Steroids. Immediately. First thing. First nurse action. And I don't know if he is, this is Nurse Mike, whatever. I don't know if he is a line item writer for the NCLEX. I think he said he was. This is NCLEX stuff. First nurse action, after you get the whole case scenario, push steroids, hydrocortisone, prednisone, whichever flavor they give you. If you don't give them steroids, they will die. This is lifelong. Taking steroids sucks. What happens?
Brittle bones.
You have brittle bones. What else? Makes you gain weight.
Doesn't it make you a high risk for infection?
High risk for infection. What are you going to educate these people?
Wear a mask. Get inoculated.
Wear a mask. Guys, how upsetting is this? What if it's a young I mean, it doesn't matter if you're my age, if you're 80, if you're 20. But how upsetting is this for a young lady or a young man, hey, you're just to gain 50 pounds. You can't go around big crowds. You can't. You don't need to have kids. All your bones are going to break. Really? Do you want to tell me anything else that's a little bit more optimistic, Doc? Right? Because these things are upsetting. But you've got to tell them this. You don't need to go around great big crowds. Why? You're going to get sick. You also need to tell them what? If you stop them steroids, right now, what's it going to throw you into? That crisis. Now, I know it says this and all the things. I know it's not possible. But there are things you can do to try to help with stress management. And they can definitely try to eat a healthier diet. So, Addison's was not enough. What is Cushing's? Too much. Too much cortisol. Why do we? Here we go. Tumors. Look. See. Everything. What is it called? Everything. Tumors. So if I've had long-term steroid usage, it can cause this too. All right, we had low symptoms. Now we got high. Hypernatremia. These, do y'all know what I mean when I say cardinal signs and symptoms? This is the elephant on the chest, the worst headache of my life. This is a round abdomen, moon face, buffalo hump. So that's right back here. I don't know any other word to say it. They might actually describe it this way. It is a fat pad, subcutaneous fat pad back here. And their face is like rounded. What does this word mean?
Excessive hair growth.
Excessive hair. Maybe not this. Huh? It is. It's kind of and it's pretty much everywhere. Not low blood sugar, high. Hypertension. So if they're taking steroids, we might need to lower them. Definitely need to monitor intake and output. If they are in fluid volume overload, they might get Lasix, they might get other things to get rid of some of that. What if their blood sugar is too high? We're going to have to give them something to lower it. I know that's not what's causing it, but we definitely have to treat it. If it is a tumor that's causing secretion of all that, that's too much, you might have to have surgery. Guys, do you think surgery in your adrenal glands is easy? It's not. When you get to messing with adrenal glands, unfortunately, they can run into a lot of problems. There is a test they can do that tests your cortisol level. I think it's saliva. Is it?
Yeah, I'm sure it's
Somebody got a, is it saliva? I think it is. Is it a 20?
urine or saliva or blood, so it's
Okay.
all three. But I think it's most common saliva, if I remember. Saliva or urine or blood.
It's not one that you normally would run unless you're thinking this, right? Why am I going to do a CMP? I want to look at sodium and potassium. I definitely am going to do CBC. And I have to look this up. I look at this every time so I don't tell people. Drugs that control cortisol production. And I cannot pronounce that drug. Ketoconazole. There we go. That drug, this is important, controls cortisol production. And there's several of them. That's the only one I put up there. They will do radiation therapy if surgery is not an option. Here again, you've got to tell people they cannot just stop steroids. It causes real bad problems. For both of these, it needs to be high protein, calcium. They need to be on a low carb diet. Infection prevention. I have never seen this. I don't ever want to see this. Pheochromocytoma. I have had a few students come back and tell me this is on, they have had a question on this on the NCLEX. Where is this gland? It's on the adrenal glands. This is usually a tumor. It is very, 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 very hard to treat. It is like that Katy Perry song, it's hot and it's cold. It's, when I say hypertension, 270 over 150, 5 minutes later, 70 over 30. 180 heart rate, 20. It is a flood of epinephrine and norepinephrine, and it just goes back and forth and back and forth. It is very, very rare, thank God. And sometimes the only thing that will stop it is to remove that. I can't even think what removal of your adrenal glands would look like. I mean, you wouldn't have any ability to respond to anything. Like I said, I haven't done a lot of research on this, but it is not.
How long does this last for? Like you said it was the,
Like back and forth, back and forth.
yeah, like, is it like a crisis?
So basically, if it puts your blood pressure up, so I never knew if this is what caused this for this woman. I have never seen the blood pressure this high. Y'all know, so what is the bottom end of a blood pressure? It's like 300, right? I think it is, or like 320 or something like that. Pumped it up to like 200 and it just started beating, and it was so loud it hurt my ears. 250, it just started beating. Pumped it all the way up to 300 and it started beating so loud it hurt my ears. I didn't even get to the bottom number. By the time it got to like 280, she started posturing and started seizing, and she went and she had a stroke right there and we flew her out. Her family was kind of iffy on her history. I always wondered because they said a few things about it, but like I said, I've only read about this in books. I don't know how fast they fluctuate. I mean, this probably would be a really good thing to do some research on, I guess. It says they can go in and try to do removal of the tumor. We really don't have any medications that treat this well. I mean, they have alpha antagonist, but if you've got something that's dumping this and then not, and dumping this and then not, you don't know when it's going to do it. So of course they're going to be having chest pain. Everything, their metabolism is through the roof. They're in fight or flight, tremors, nausea, vomiting, heat intolerance, hypermetabolism. You're going to have them in a low stimulus environment. I mean, I guess they could start seizing. and have a stroke. EKG, LOC, full set of vital signs. So these are alpha blockers, alpha 1, phentolamine, beta blockers. I mean, you're treating the fallout here, but you can't do anything else if their heart rate's 200. They do make a test that's urine catecholamine. I guess that would let you know if that's what's happening, or they'll do an adrenal biopsy of the tumor. CT, MRI, and so if they do the CT, they can see the tumor, right? And they'll do the adrenal biopsy. Sometimes it's not malignant, but it don't really matter if it's malignant if it's causing all these problems. And then they can try to go in and do surgery. Questions?